Okay, students, I am going to start this recording off at the beginning of chapter 21 because we kind of raced through a few of the slides. So we're going to be talking about premature rupture of preterm labor. So if you remember, preterm labor is anything after 20 weeks to 37 weeks. That's the preterm period. Anything before 20 weeks is an abortion. But anyways, we educate our patients in the clinic that they need to call the doctor or report to the hospital if they feel 4 contractions in 20 minutes or 8 in an hour. And then when we check them, then we see a cervical change from our last exam. So she gets further evaluation. Now the problem with that diagnosis, or those criteria for diagnosis, those 4 contractions in an hour, is Braxton Hicks. You can have 4 contractions, or 20 minutes, sorry, 4 contractions in 20 minutes. So it's hard to tell, are these Braxton Hicks or are these signs of preterm labor? So don't ever ask that question. If they're having contractions, described like that, then they probably should be evaluated. So they can just be having some menstrual cramps or just some mild abdominal cramping. They can have a back pain, backache. They can have feeling pressure, pelvic pressure, change in their vaginal discharge, all pretty vague except for the rupture of membranes. They could be having leaking fluid, or they could have a big old gush of water, but all pretty vague and could mean absolutely nothing, but could mean she's in preterm labor. So these can't be poo-pooed, and if she comes to the clinic or calls, you need to have her come in. She needs to be evaluated. Here's some predictors of preterm labor, and like I said in class today when we rushed through this slide, is try to think of these things, not trying to brute memorize them, but trying to understand why they would apply to preterm labor. Okay, and so it's not like your patient's going to come in and you're going to have to try to think of things to look for in her to see whether or not she's in preterm labor. Like when you hear multiple gestation, you're going to automatically think that this woman is at risk for preterm labor because she has lots of fetuses in there that could put too much strain on the uterus or the bag of waters and cause this woman to go into preterm labor. So some of these things I really want you to try to think about how they apply, so it's not a brute memorization type deal. We did quickly go over the medications that we could be giving for preterm labor. Tributaline or breathine, which is a sub-Q injection that we give in the hospital. Magnesium sulfate is that drug we were talking about for preeclampsia. It's a IV drip medication. But the Indocin and the Procardia, those are medications that she could be sent home on and be taking every 4 to 6 hours. I think Indocin is, and Procardia is, can be once a day, twice a day, or 3 times a day. All right, so PPROM, or PROM versus PPROM. So these are just definitions, just like the gravida, parity, and all that kind of stuff. These are definitions, terms that we use in the OB community. So when someone says she's PROM, then they're talking about that her water broke and she's not in labor. Okay, and then if they're talking about PPROM, then it's a preterm rupture of membranes, not in labor. Okay, so we get PROM patients in that their water broke, and so they come in, I think my water broke. Oh yeah, your water did break, but you're not contracting at all. Great. So sometimes we might just give her a couple of hours and see if she kicks into labor, and then most often we end up starting Pitocin to get the labor going. PPROM, on the other hand, So she's a preterm premature rupture of membranes. This is before 37 weeks. This could be 28 weeks. We have a lot of patients at Community Medical Center that basically live there as long as we can keep them pregnant that are PPROM. Their water breaks and they're not laboring. They're not in labor. And if baby's tolerating that, if mom's tolerating that, not getting infected, baby is not, or mom's not bleeding, baby's not having bad heart tones, we will continue that pregnancy as long as we possibly can. So if, for instance, if she's a 28-weeker, we will try to keep her pregnant as close to term as possible. We've gotten to 36 weeks before. We've gotten even as close as 37 weeks with these people being ruptured, but not laboring. So that's the key. Here are your risk factors for PROM or PPROM. Here's some more risk factors. All right. So if you guys, I should have mentioned this before I started, but if you listen to this lecture and you have any questions, please just email me, okay? Or we'll talk about it next week in class because you're not having the exam on this content until not this Sunday, but the following Sunday, which is the 13th. Okay? All right, so now we're talking about other bleeding issues in pregnancy. Placenta previa, which is a low implantation of the placenta in the lower uterine segment. So this can cause bleeding depending on how close that placenta is to the cervix. So there's 4 types, of course. There's the complete, partial, marginal, and low-lying. The complete is the placenta completely covers the cervical os. So whatever portion of the placenta is over the cervix is bleeding. And then if we were to allow that woman to labor and dilate as that placenta opens, it exposes more as that cervix opens, it exposes more areas of the placenta. So these women cannot deliver vaginally. The partial previa is the placenta is partially covering the cervical os, and that small part is bleeding. And if we allow this woman to dilate, the more she dilated in labor, the more she's going to expose that placenta. The marginal previa is the edge of the placenta is touching the edge of the cervix, and so the more this woman dilates, the more she might expose the placenta. So maybe we'll have to just see how it goes, or maybe she'll just automatically get a C-section. The low-lying placenta, this woman can deliver vaginally. The placenta is low in the uterus, but it's not touching the cervix. So as that cervix dilates, if that placenta is far enough away, but still in the lower segment, it won't be bleeding out the dilating cervix. So this woman can deliver vaginally. So here's just a picture of a low-lying placenta, and you see that cervix can dilate, and hopefully there will be no placenta exposed and no bleeding problems. Here's your partial previa. This is the one that's going to need to be delivered by C-section. This isn't a very great picture because of its animation, but as that cervix dilates, it's going to be exposing that placenta. And then here's your complete. So it's completely covering, no way that baby can deliver through that placenta. Okay. All right, so here's your risk factors for placenta previa. Now, as far as the baby is concerned, it really does depend on the extent of the previa and how much bleeding this woman is having. So, if she has that complete or partial, we're going to be going straight to C-section. But if she has the low-lying, we're going to be constantly monitoring baby and mother as well to make sure that we're not having any issues with bleeding. Here's your indications for cesarean, C-section birth. So if you have a woman that has a low-lying placenta, and maybe mom starts bleeding through labor, and we start having bad, non-reassuring fetal heart rate rates on the monitor, then we will deliver C-section. So this bleeding that the woman's having, the big key here is that it's painless, okay? Because she's not really contracting. It's the exposed placenta is just bleeding, okay? And then ultrasound is how we determine the extent of the previa. So depending on where that placenta is sitting in the uterus, low-lying in the uterus, it could affect the way baby presents or is laying in there. So if you have this big old bulky placenta in the lower part of the uterus, you can imagine that there might not be room for baby to be head down. So it might affect how baby is laying in there. So you might get a transverse lie. But we're going to do continuous fetal assessment. She's going to be on continuous external toco-dynamometer, and that is the contraction monitor part. We're going to watch mom's vital signs every 15 minutes because she's high risk, and placenta previa makes her high risk. And then if she's actively hemorrhaging, the hemorrhage protocol is every 5 minutes. So our care for the baby is really dependent on how they handled this situation. So if baby comes out pink and screaming and kicking all around, then you know we'll just keep monitoring baby, keep watching baby, keep assessing baby. But if baby had any type of prolonged asphyxia, if there was a large blood loss, then we may be this baby may be admitted to the NICU and having oxygen and IVs of themselves. They may have blood transfusions. We'll be doing labs. They do all kinds of crazy things in there to babies. All right, so the other bleeding issue is abruptio placentae. So this is when the placenta separates from the uterine wall, and this may have nothing to do with labor at all. So this woman doesn't have to be in labor. She doesn't even have to be term for this to happen. This can happen preterm, and this can happen for a whole host of reasons, and here are some of those, okay? Cocaine use is a big one. Trauma to the abdomen is a big one, okay? Over-distended uterus is a big one. Here's some more risk factors. Okay? And a few more. So you don't need to, again, you don't need to be memorizing these, but when you see these things in your patient, you just need to be on suspicious and of an abruption and monitor her. Doesn't necessarily mean she's going to have one, but these are things that could put her at risk. So guess what? There's 3 different types of placenta abruption. There's a marginal, a central, and a complete. So marginal just means that part of the placenta has separated from the uterus, and that part is bleeding, and it bleeds out of the uterus, out of the cervix, through the vagina, and so we see this bleeding. The central abruption, the outer edges of the placenta still are adhered to the uterus, but there's an inside portion that has separated, and the bleeding is contained within that separation. It doesn't have a way to escape, so we don't see this vaginal bleeding. And then the complete abruption is the entire placenta has separated from the uterus, and this does cause massive bleeding and is a obstetrical emergency. So here are some pictures of the marginal abruption, and you can see here just a small part of the placenta has separated, and then it's bleeding from that part. Now, this doesn't require immediate delivery unless the bleeding does not stop. There are a lot of women who have had an abruption. It was undiagnosed until delivery. She had some bleeding. Maybe they did an ultrasound and they couldn't see it. The bleeding stopped, and every mom and babe looked good, so she continued her pregnancy. And then whenever she did finally go into labor, and the placenta was delivered, the physician inspects the placenta, and he notices that there was a part of the placenta that had abrupted and clotted off. So hopefully that's the case, but if it doesn't and she continues to bleed, then we will need to do a delivery. Now, depending on the facility you're in, if you're in a tertiary birthing place like CMC is, then you might be able to labor this woman if you can keep track of her bleeding. If mom is not hemorrhaging, like it's not a huge bleed, like maybe it's just a little tiny bleed, and we can get this woman to dilate and deliver her baby, that's great. However, most of the times with an active bleed, it does sometimes mean a C-section. So same thing with your central abruption, and you can see that picture here. Again, these may occur, they may go undiagnosed, and they end up at term, they deliver, and then physician then notices after inspecting the placenta after delivery that it had bled and clotted. But this is kind of a dangerous one, because if it continues to bleed and we're not seeing the blood loss, the patient isn't seeing the blood loss, then this could be a problem. But the one light at the end of the tunnel here is these are painful. The woman does feel pain. When we palpate her uterus, it is rock hard. It doesn't relax like you would see between a contraction. It stays hard all the time. And then, here's a complete abruption. The placenta has completely separated. There's no putting it back together. This needs emergently delivered. All right, so of course your mom is at risk for hemorrhage, shock, and DIC, and then with the baby, it's just dependent on the degree of the abruption, how well baby does or how bad baby does after delivery. So she's going to be on continuous monitoring and continuous assessment of uterine tone, and that is a palpation by the nurse. We can do measure abdominal girths to try to document bleeding, and then monitor her for potential for DIC. So we're going to keep track of her clotting factors and try to prevent a DIC from happening. So a cesarean is the safest option for someone who's actively bleeding, of course, but depending on the degree of the abruption and the facility's ability to handle this patient, they may do an induction. So we do want to protect her against, or do what we can to decrease her risk for DIC. We'll have blood type and crossed. We'll be watching her clotting factors, administering IV fluids and blood products as needed. Central venous pressure monitoring. So if she has this, like I'm thinking that she will be in an ICU setting with a labor nurse and an ICU nurse in attendance. So, for a woman who's bleeding, that we definitely want to monitor all these things, okay? And keep track of how well she's handling this, and deliver, intervene, give blood, or whatever we have to do to control her response. All right, now we're going to move on to cervical insufficiency. which was once called incompetent cervix. But this is a painful or painless dilation of her cervix. Usually it happens in the, well, it happens early, sometimes first trimester, second trimester, okay? But she's not having contractions. And her cervix is dilating anyway. So this is a big problem. Here are your risk factors for cervical insufficiency. So with cervical insufficiency, of course we're going to do surveillance and watch her cervix. Actually, we're going to be measuring her cervix. This is a little different than dilation. So cervical length. So your cervix is, if you remember from these previous pictures, the cervix is long, and so it has to shrink or thin out and dilate for a woman to deliver. So if we keep track of those lengths of her cervix, if we keep seeing her cervix getting shorter, then she's at huge risk for delivering preterm. So our therapies, yes. So we're going to continue doing these ultrasound assessments. We're going to put this woman on bed rest. She might be on progesterone supplements, and this will hopefully keep her cervix from dilating. She may be on antibiotics, anti-inflammatories, but this is the key right here. This is the key treatment right here. So if you have a woman with cervical insufficiency, we do this cerclage. It's a surgical procedure where they kind of stitch the cervix so that it won't dilate, okay? And a lot of times this is very effective and allows women to go to term. And usually between 36 and 37 weeks, they cut that stitch. And then so whenever she goes into labor, that's great. Now there's a couple of different kinds of cerclages. There's the elective cerclage. So this is placed hopefully before she starts dilating. So this is the woman that we know has a problem with cervical insufficiency. So we're going to place this stitch before she starts dilating, okay? The emergent cerclage is she has already started dilating, so we're going to hurry up and throw that stitch on and hope that we stop her dilation. Not as successful as the elective cerclage, but if this is the first time she's had a pregnancy or the first time she's developed cervical insufficiency, at least, then we don't really know until it's kind of too late, not too late, but we don't really even know until she's already started dilating. So the elective cerclage is, we don't know to do that, okay? The abdominal cerclage is basically with a cervix that's got some really bad problems anatomically. They go in and they and put this big, it's pretty much the same, but they put this big old loop higher up on the cervix, or the lower uterine segment even. So anyways, these are all possibilities for someone with a cervical insufficiency. All right, now we're going to talk about hydramnios and oligohydramnios. So these are amniotic fluid problems. Hydramnios is too much amniotic fluid. They used to call it polyhydramnios. Now they just call it hydramnios. But too much amniotic fluid, greater than 2,000 cc's. Okay. So what happens in utero is the fetus swallows amniotic fluid, inspires some amniotic fluid. The baby urinates. So the fluctuations in amniotic fluid are constant. But if we have too much amniotic fluid, then there's something wrong with one of those features. like baby's not swallowing well, or a baby's not having those inspirations occasionally, or baby is not urinating, so we have a kidney problem. Okay, so something's wrong on baby side, that we have too much amniotic fluid. So the only treatment for amniotic or hydramnios is one, just to monitor the pregnancy, of course, but if it starts becoming a problem for the woman and or the baby, then we need to do fluid reductions, and that's similar to amniocentesis. We go in with a needle, just like with an amniocentesis. We draw off fluid, just like an amniocentesis, but we might be drawing off massive amounts of fluid. So we had a patient a couple summers ago at CMC, ungodly amounts of fluid we took off of her a couple of times a week, like liters of fluid. It was just crazy. But anyways, and the other thing is, I think this gal was really short, so oh my gosh, she just looked miserable. But anyways, so you can imagine if you had this huge uterus full of all this fluid that is going to put pressure on your diaphragm, it's going to make it hard for you to breathe. The other thing is it's going to put pressure on those vessels that drain your lower extremities, so they're not going to get adequate drainage, so you're going to see lower extremity edema. All right. Here's the risk factors for hydramnios. And you can see how some of these might apply. Prolapse cord, so you got this huge pool of water, and if the bag of waters break and all that fluid comes rushing out, it's probably going to kind of wash out the cord as well. Okay. So anyways, here's your risk factors for both the pregnancy, for mom, and for baby. And then here is oligohydramnios, which is the opposite. It is not enough amniotic fluid, less than 500 cc's. Largest pocket means when they do an ultrasound and look at things in the uterus, they'll find pockets of fluid, you know, like between the baby's knee and elbow or something like that, or between the baby's head and shoulder, there's a pocket of fluid. And anyway, so that's less than 5 cc's, a measurement they do, okay? Not specifically a volume, but how large is that pocket? Anyway, so if we don't have enough fluid, that's probably because baby has a kidney problem where he's not peeing good, intrauterine growth restriction, maternal risks, dysfunctional or long labor. So having a uterus with not enough fluid in it doesn't really present a lot of problems for the pregnancy, except when it comes to the labor. And then fetal skin issues. So when you don't have a lot of fluid in there, can you imagine this developing fetus, and there's not enough fluid developing along with the fetus, so as parts of the babies are developing, if they don't have fluid to lubricate, then those parts are going to kind of stick together, so you get those fetal adhesions. Cord compression is huge, so we do have patients in the hospital that have oligohydramnios. They're not contracting, but because there's not a lot of fluid to cushion in there, the cord does get compressed. Okay? All right. So when we have a patient with oligohydramnios, we'll do some serial testing, and as long as everybody's okay, you know, we don't jump up and down, but we'll be doing our non-stress tests and or biophysical profiles. We'll be doing ultrasounds regularly to keep measuring the amount of fluid we have in there, and as soon as we can, we will induce labor. When we do that, we need to, she'll be on continuous monitoring, of course. Now, amnio infusion is something we can do for a woman who their bag of water is ruptured. So she either has a true oligohydramnios, or we broke her water and all the fluid has come out, so we're causing cord compression. Either way, we can do an amnio infusion, and so what that requires is the internal contraction monitor. So it's a catheter similar to a Foley catheter that is placed in the uterus and connected to our monitor, but that also that measures her contractions, but it also has a port on that catheter that we can hook up to IV fluids, and we can infuse IV fluids into the uterus to start creating more volume of fluid in there to cushion the cord, so that maybe this labor can continue to delivery. Maternal repositioning is also a big treatment for oligohydramnios. So if you've got a cord that's being compressed, if you switch mom's position, maybe you get the pressure off that cord. IV fluid boluses is another thing that we can do to help create more blood volume in mom, which will also help create more fluid for baby. Variable decels are the decelerations, if you remember from our lecture the other week, is variable decelerations show us cord compression. So as that fetal heart rate is tracing, if we see these variable decelerations, we can safely assume that the cord is being compressed. All right, here's the last of the few slides I'm going to go over with you quickly. So we're going to talk about versions. Okay, so your external version. So this is done hopefully at 36 weeks on a breech baby. We want to do it as close to 36 weeks as we can for a couple reasons. One is there will be enough room to try to do this version, or to turn baby from a breech presentation to a head down presentation. There'll be enough room, but then also hopefully we're close enough to term that maybe baby won't turn back. Who knows? But anyways, the physician does this procedure, and he externally tries to maneuver baby and manipulate mom's abdomen and scrunch baby around to try to get baby head down. If the presenting part is engaged or stuck in the pelvis, of course we're not going to be able to do this. And then we need to do a non-stress test to determine fetal well-being. And then we will give a tocolytic like the breathine that we discussed earlier to relax her uterus. And then also pain medication, because this isn't a comfortable procedure for mom. And then if we get this baby turned, then mom goes home, and hopefully baby stays head down, and she gets a couple more weeks under her belt, and then comes into labor, and baby's head down, and she can deliver vaginally. Now the internal version, this is done on multiple gestations. Okay, we're doing a vaginal delivery on, let's just use a twin gestation for an example. The first baby is head down and the first baby is delivered. Mom pushes that baby out. But then the second baby is way up there in the uterus, or maybe the second baby is breech. So the physician will go in through the vagina, in through the cervix, into the uterus, and grab the baby and try to turn the baby head down, if at all possible. Now this says, this slide says the physician reaches into the uterus and grabs the feet of the fetus and then pulls them down through the cervix. This is actually not the greatest, this is not the first thing that they try. They try to put that second baby head down, and then they let the woman push this baby out head down. However, if for some reason that can't happen, they can't get the baby turned or whatever, so the physician could just grab the feet and pull the baby out breech. However, there are not a lot of physicians that would be willing to deliver a baby breech, even in this circumstance. I have experienced most of my physicians, if they can't get that second baby turned, that they will do a C-section and deliver the second baby by C-section, even though the first one was delivered by vaginally. So I do know of one physician in particular who will just go ahead and deliver this baby breech. He has a lot of experience doing that. His technique is is great. So it's very dangerous to deliver a baby breech. But anyways, you can give tocolytics like that breathine to relax the uterus to make this easier go. But if you do that and you plan to let the woman deliver the second baby vaginally, in other words, push the baby out, and you give tocolytics to slow the contractions down or make them less strong, then we're going to have to do something to kick those back in. All right. Amniotomy is just, well, the purpose of an amniotomy. Okay, so amniotomy is breaking a woman's amniotic bag with an amniotic hook. Okay, we do that ourselves, or the physician does that themselves. The reason why we would do this is to stimulate or induce labor. So to stimulate labor, maybe this woman's in labor, she's dilating really slow, it's going really long. If we broke her bag of water, that would actually make the contractions stronger and more frequent, so hopefully cause quicker dilation. So that's stimulating a labor. Inducing a labor is similar to the PROM, the premature rupture of membranes before the onset of labor. So it's similar to that, but we want the labor to come. So if we're inducing labor, she's not in labor, we are going to try to start labor, and we can do that by breaking her water or bag of fluid. The other reason why we might do that is so that we can apply a spiral electrode for tracing baby's fetal heart rate, and we can put in the intrauterine pressure catheter, the internal contraction monitor. The amniotic bag needs to be ruptured in order for us to put these internal monitors on. We could do a fetal scalp pH. The water does have to be broke for us to get to the fetal scalp, of course, but we don't do these. These are not a normal part of practice. We would do a scalp pH on a baby that was having non-reassuring fetal heart rates, that for some reason we absolutely did not want to do a C-section. The mom didn't want to, or whatever the reason. So if we're having bad fetal heart rates, then we really need to know about baby's oxygenation status. So we would do a pH to see that. But we don't do those anymore. They're not as accurate as we would wish they were, and then they set the baby up for infection. So we just don't do these anymore. If we have bad baby heart rates, we'll do everything we can to alleviate those bad heart rates, and we'll sit on them as long as we can to get to a vaginal delivery, but there will be a point where we will say enough is enough, and we will deliver that baby by C-section. The other thing is we can assess the color and composition of the amniotic fluid. So when the water breaks, we want it to be clear fluid. It can be bloody because, it's okay to have some bloodiness in the amniotic fluid. What we don't want is we don't want any shade or any consistency or shade of green. So if we have green amniotic fluid that looks like green lemonade, or we have green amniotic fluid that looks like pea soup, then we've got a problem, either one of those. Okay, that means baby is under a severe amount of stress and has had a bowel movement in utero. And so we can continue the labor if that happens, but we need to have a NICU team at the delivery for that baby. If babies are born with meconium, If they come out of the vagina screaming their head off, then we let the baby be a normal baby. But if they come out, they don't take a breath, and they're limp, we immediately put them on the warmer. We intubate to visualize cords and anticipating that we're going to need to be suctioning meconium out of the airway. So we want to do that as quick as possible before baby takes their first breath and inhales that meconium down into the lungs. If you deliver a baby that comes out screaming, it's too late. And if they're screaming, then they're well. Sick babies that have aspirated meconium do not scream. Okay. All right. I'm going to review really quick what we do for induction or cervical ripening, or preparing the cervix for induction. So before we even think about inducing, we can do cervical ripening. And this is just to soften the cervix, thin out the cervix so that when we do start the induction, that the cervix will dilate better. Okay. So the ways we can do cervical ripening is we have a couple of medications we can use. Cytotec and Cervidil. So Cytotec is a tablet, is a pill that we insert vaginally up to the cervix. We give this every 4 hours until we get a regular contraction pattern. And sometimes we give them 1 dose and we get a regular contraction pattern. Sometimes we have to do 3 or 4 doses. But we do this until we get a regular contraction pattern. Now, Cytotec does not induce labor. It softens the cervix. But because of that irritation, it causes contractions. And if she's contracting regularly, we need to stop giving Cytotec because we can cause hyperstimulation of the contraction pattern. Or the correct term is tachysystole. But basically it's a hyperstimulation, so she's having we cause too many contractions. Anyway, so she needs to be on continuous monitoring so that we can see this. We need to have IV access, and then we do frequent maternal vital signs. Now with the Cervidil, it's prostaglandin on a rope, basically, or soap on a rope. It's the prostaglandin medication is in this little fabric-y looking thing, thin, and we insert that into the vagina up to the cervix, and then it's connected to a string. We leave that in for 12 hours and then we pull it out and then we start her induction. However, within that 12 hours, if we cause a hyperstimulation of her uterus, we can just pull that Cervidil out. Unlike the Cytotec, we cannot pull this little tablet out, okay? So I prefer Cervidil over Cytotec, but I prefer, oh wait, no, here we go. So Cytotec, it's 25 micrograms given every 4 hours. And then the Cervidil, it's a 10 milligram prostaglandin insert. We put it in, leave it in for 12 hours, and then pull it out. But this is my favorite here. So not medication, but an actual device we can use to ripen the cervix. It's called a cervical ripening balloon. And it's really similar to a Foley. So if you think about putting a Foley into someone's bladder, you insert the Foley into the bladder and then you inflate the balloon to hold it in the bladder. This is very similar. We insert this catheter in through the cervix into the uterus. There is a balloon that we inflate that holds the catheter in place, but more so it's putting pressure on the cervix in on the uterine side, and then on this that vagina side there's also a balloon on that side that we inflate, and so those two balloons are now squishing the cervix. Okay, so if you can imagine that. Anyways, the reason why I like these is because they're not medications. They don't need to be on continuous monitoring. Some physicians are putting this in the clinic and then sending the patient home and instructing the patient to come to show up at the hospital at like 5 in the morning or something like that, or come to the hospital if sometime in the middle of the night the balloon falls out. If the balloon falls out, that means she started dilating. So she might be in labor, so she needs to go to the labor unit. So these are great. All right, the other thing that we do is, and actually your physician will do this in the clinic, is stripping of membranes, okay? So in the clinic, they will kind of do like a vag exam, and they will kind of twist and not scratch, but twist between their fingers, rub between their fingers the amniotic bag, okay? And so hopefully what this does is it releases prostaglandins, prostaglandins, and causes this woman to go into labor. Sometimes it happens that night, or sometimes it's not for a couple of days. All right, once we've done all these things, what the patient will have done for induction is a Pitocin infusion. Pitocin is a hormone that, oxytocin is the other name of it. We produce it ourselves, but the exogenous kind is called Pitocin. And it's an infusion that causes frequent and strong contractions. And we need to have this patient on continuous monitoring, and there is a very stringent protocol to follow to run Pitocin. So it does cause frequent, strong contractions, so we need to make sure we don't cause too many contractions, hyperstimulate, or too strong contractions, and risk a rupture. It also, contractions by nature are a stress for baby. And most babies, hopefully, are healthy enough to endure labor and contractions, but we're going to be causing more contractions with this Pitocin, so we need to constantly monitor baby as well. But anyways, there's a very stringent, precise dosing regimen. We have to assess mom, her vital signs. We have to assess her contraction pattern and the fetal heart rate status, usually about every 30 minutes. And then we decide whether or not we can increase our Pitocin rate. If everything is good, we can increase our Pitocin rate. If baby is good, but the contraction pattern is too close, then we need to turn our Pitocin down, and the protocol is we just cut it in half. If the baby's not good, then we turn the Pitocin completely off. Okay, so that's the difference. So here, I'm going to say it again. If the baby is good, in other words, what I'm saying is her heart rate tracing looks good, normal, but we have too many contractions, we just need to cut our Pitocin in half. Okay, that's all we need to do. If we are assessing and our baby's fetal heart rate tracing looks bad, we turn the Pitocin off. Okay, we give our babies a 30-minute rest period. We resuscitate our baby, provide turn mom, reposition mom, give IV fluids, maybe even oxygen. We try to resuscitate our baby in utero, intrauterine resuscitation, and then when our baby recovers, then we can start our Pitocin over, or start it back, and then start over at the beginning of the protocol. Here are reasons why we would abandon our labor and go to C-section. So fetal distress. So we have bad baby heart rates that we can't fix. We need to get baby out. Active genital herpes. They are automatic C-sections. Multiple gestation, 3 or more. So twins can deliver vaginally if we can get both babies head down. But anything beyond twins is a C-section delivery. Umbilical cord prolapse is an obstetrical emergency. Immediate emergent C-section, stat C-section. This is when the water breaks and the water rushes the cord out. So the head then comes down on the cord that is pinched between the uterus or the cervix and the baby's head. you can't put the cord back in. You have got to do a vaginal exam. You have got to find the presenting part and push it up off the cord so that you can now regain blood flow to the baby, and then you hold your hand there until they C-section that baby out. Okay. Anyways, lack of progress. So you're doing everything you can. You've been trying to labor this patient. You've been using Pitocin. You can't get her to dilate. It's not working. You go to C-section. So here's some other indications for a C-section. Okay. All right. Real quick about C-sections vaginal births after C-sections. Some facilities allow these, some do not. They are called trial of labor after cesarean birth. They used to call them VBACs, but they're called TOLACs now, trial of labor after cesarean. So at CMC and St. Pat's, women can opt for trial of labor after cesarean. Some facilities are not set up staffing-wise to allow this to happen. The standard is that you have to have an OR crew on standby in the hospital for her entire labor until she delivers, because a risk of labor with previous C-section is a ruptured uterus. The two instances for sure anywhere in the world that cannot have a trial of labor is a classical C-section or an anchor C-section. This is a normal transverse C-section. This is where they'll cut, okay? This is normal. So a woman can have a trial of labor with this a previous C-section. If you can see from the picture, it's in the lower uterine segment. So the bulk of the contractions for labor are in the upper part of the uterus. So they are still at risk for rupturing that scar, but it's a very low risk. So they'll let these women trial labor. This is another normal incision that not too many obstetricians use anymore, but she could do a trial of labor after this type of incision. This is the classical incision. A classical incision is used for an extreme emergent cesarean delivery. This is the fastest incision to do to get baby out. Okay, so you see that incision is in the bulk of the body of the uterus where most of those contractions are occurring, and this incision will not withstand contractions. And then the anchor is if you combine this incision, so they cut this incision on some normal cesarean delivery, and for some reason they couldn't get the baby out, okay, or something was going on with mom, or some craziness was going on where they needed baby out that very second. They've cut this incision, they can't get the baby out, so then they throw this one on there. So you can see how that makes an anchor. They cannot have a cesarean delivery with this one, with the classical or the anchor incision. All right, I'm sorry guys, that's a lot of content, but thankfully you have a couple weeks to review that. Please let me know if you have any questions, either in email or we can try to discuss in class next week.